And then Dr. Rohit said that this is a surgical strike. So we want you to be speaking on something besides your IL preferences. So I wanted to share some tips on, as I said before, on my experiences with topical versus intraoperative mydriasis with intracameral drugs. And I have no financial interest. Uh, so mydriasis, we all know, is a prerequisite for safe cataract surgery, and most surgeons require a stable, good, adequate pupil dilation. And intraoperative meiosis can cause complications of all kinds. We all know that. I don't have to go into the details. Intraoperative meiosis and sequelae can further jeopardize the final outcomes, and we are all looking at 6-6 outcomes now. So pupil mydriasis becomes an absolute must, and an adequate one and a stable one at that. So it's probably the most important factor we all are looking for right from the time we start doing our residency, that is the pupil well dilated, and it's like a fixation for all of us. It facilitates all our surgical maneuvers, especially when we are using toric IOLs. We would definitely want an adequate mydriasis as well, and definitely goes in improving the quality of cataract surgery. And in one survey which I came up on, the European Observatory indicated that stable mydriasis was more important to surgeons than the largest size of dilation to begin with at the surgery. So we've been all using and mydriatic drops of all kinds, and we've come a long way. The only things that probably stand out as being difficult with topical mydriasis is gradual onset of mydriasis. Could take anywhere from 15-20 minutes to an hour or even more for those difficult cases. Limited bioavailability, and then of course you have to use multiple drops, which can possibly damage the ocular surface. Sometimes you may have inconsistent mydriasis and intraoperative pupil meiosis in challenging cases, and systemic absorption and allergies. So we now have good options available. Internationally, they've been available for long, and now in India, we also have another option available, which can be used, and can be used as an adjunct, or it can be used even alone for prompt onset of pupil dilation, stable mydriasis, also combined with lignocaine injection. So better anesthesia, can be supplemented at any time. Of course, we've had access to epinephrine and adrenaline for long, but we've all been hesitant to use it on a regular basis for fear of endothelial damage. And of course, there is less risk of systemic exposure. Several studies are there. Let me come to some couple of unique cases that I wanted to share with you. This was a lady who had to be postponed 3 times because she would every time, for almost all drops, including our topical antibiotics and our topical mydriatrics of all kinds, she would get an allergy. So we had to go ahead with a surgery where nothing was used for the previous few days. And this was a learning case for me about a couple of years back. And we had this patient. We decided to use only intracameral phenocaine, which was under trials with me at that time. It's basically a combination of phenylephrine, tropicamide, and lidocaine. And you can see that it gives you fairly rapid onset of mydriasis. So it gives you a fairly stable mydriasis. Of course, you can see that the pupil size is not that great, but this patient's pupil size, the biggest pupil dilation preoperatively examined, was also just about 5.5 to 6 millimeters. So this was the best mydriasis we could have hoped for, and it allowed me to complete the surgery. And mydriasis remained right till the end. I did not have to supplement it. So this was a learning case for me almost 3-4 years back. And of course, we do have access to all kinds of devices. So this was another challenging case where I felt that intracameral for us. This was a hard brown cataract with mydriasis, which was only preoperative mydriasis was not adequate, and we were anticipating problems with this patient. We stained, and as soon as we washed out the trypan blue, we realized that the pupil had come down. And I love to do viscomydriasis. In fact, I don't jump to devices right in the beginning. In fact, 90-95% of my cases I can usually manage just without use of any of this pupil expansion devices, because if you have a 4 mm or slightly bigger pupil, you can usually get away, unless you have a case like this where it's really hard. So at this point, we decided to use intracameral phenocaine, and we thought that this might help us. This patient also had a floppy iris. It was a suprahard cataract, as you can see. This is a fast forwarded video because it actually went on for much longer than what you'll see here. And I was able to crack the nucleus and do lateral separation. But by the time we finished cracking the nucleus completely, the pupil had started coming down enough that I was challenged. And I used intracameral phenocaine at this time because I was not able to appreciate the rex's edge, and my maneuvers were becoming more and more dangerous. So one option would have been to switch to devices. I could have gone on. I don't like using any of the rings at this point, because once your rexus is there and you can't see the rexus edge very clearly, I would have preferred to use iris hooks. So I was already preparing to get the iris hooks, and then thought that if I'll just use phenocaine here, it might just help me. And we did manage to complete the case. So it sometimes works. In fact, most of the times it does work. And you can see here that I was able to complete the case. And my dresses remained, in fact, right till the end, more than what we anticipated, and I was able to do a comfortable IOL injection. There was another case where a patient had been referred following a cataract surgery which was aborted elsewhere. And there was a patient doc surgeon who had a PC rent, and had referred with a vitreous loss, did not have a working vitrectomy set up there. So we went in with also patient had a small pupil. So we did a vitrectomy, and by the time we managed to get the cortex out uh, from the bag, the pupil started coming down. And at this point, I had to put in a three-piece lens into the sulcus, but you can see that the pupil has become really small, and I'm not able to visualize the rexus. So we started off with a much better sized pupil, and I was struggling to get this using a bimanual approach, trying to get that haptic in. But the tone of the pupil was enough that it would not allow the haptic to stay there. So I struggled 2-3 times, but it would not go. At this point, I decided to use intracameral mydriasis, and was able to, we were able to get a quick dilation within few seconds, enough that I now had more ability to let the lens in, and I was able to finally manage and get the haptic in, and we were able to save the day. And it went off well. I'll show a last patient here, where again we it saved the day for us. Femto is known to cause sometimes intraoperative mydriasis and miosis, and especially if you're lining up 3-4 cases together, usually the last one will have meiosis like this sometimes. And here we realized right from the beginning that this pupil was not going to be adequate. I put in phenocaine, and you can see that now we have a very adequate pupil. Just see how I started off with. It was pretty bad, and with phenocaine I was able to get, I was again preparing my devices. So what I really wanted to say was that uh, this is a good option before jumping on to any of your devices. This can really save the day. For me, it has worked quite well, and I rarely use devices now. Of course, there are those patients where it won't work, and I'll bypass this. So quickly coming on to 4 slides to show what my IL preferences are, which I was meant to speak on, but Dr. Rohit suggested I speak on a surgical topic. So for monofocal IOLs, I would like to use a hydrophobic lens with a square edge, reliable injector system, preloaded if possible, and I like to do hydroimplantation, so that's my preferred technique. Wanted to share this small video clip of 10 seconds. This is the lens which I currently prefer to use. I think you saw this right in the beginning of the presentation. It's a beautiful lens. It's a preloaded lens from Nidec. I do hydroimplantation, so I like to use a shooter. And we all know that preloaded lenses is the way to go. Almost all companies are now moving to preloaded. Now, the advantage I find with this injector system is that, even with a wound-assisted injection, with a 2.2 incision, I don't have to. You can see that the cartridge tip can actually go well inside. So, you don't have to do a wound-assisted all the time, and it's a very predictable injector. It has a small groove at the bottom which allows delivery of the haptic in a very perfect way. And so it comes out very beautifully, and there is no rotation. So this would be my choice for a monofocal preloaded. For monofocal extended depth, we have good options available now. I will not go into the details, but I like to use wherever patient wants a near ability but does not want any of things which go with a multifocal lens. I would go for a EDOF lens. Toric IOLs, I don't have to speak, because I think 35% of our practice, all of us surgeons who are doing torics would be happy to use torics. There is no question mark on that. And my last slide on multifocal IOLs, I think we've moved on completely from bifocal IOLs to the trifocal IOLs, which seem to have great ability now, and we have several available. So there are 3-4 of them, and I try to choose them between them, for depending on what kind of ability that the patient wants. And definitely torics, with my threshold to switch to toric, my trifocals is very low. And I think with that, I will stop. I'm sorry for having exceeded the time by 1 minute or 1.5 minutes.